Okay, we're the three Gynae cases reviewers. There's myself, Karen Joshi, Emma Reynolds and Annie Majoka. We're just going to go through a couple of topics that we're being referred commonly and just do some top tips in the history and any investigations and findings that would be useful to know in the referral letter. Okay, so top tips in the history for menorrhagia would include what the woman's cycles are like now, so the length of the bleeding and the gaps between periods, and compare this to previous cycles and how it differs. An idea of what contraception she's been on in the past and what she uses now, if any, will be useful to know, and any other medications that you've tried already for menorrhagia, such as tranexamic acid, mefenamic acid, combined pill, etc. The presence or absence of any intermenstrual or postcoital bleeding would be good to know, and any other risk factors for endometrial cancer, such as polycystic ovarian syndrome, diabetes or raised BMI. Examination should include swabs if indicated, so any history of discharge, smell, itch, etc., and a smear if it's due. Following on from that, some routine investigations for menorrhagia, obviously full blood count to exclude anemia, plus or minus TSH if it's indicated, and then an ultrasound scan of the pelvis, preferably transvaginal if the patient will accept this. Primary care management of menorrhagia includes correcting any iron deficiency. If you have a normal scan, then discuss Mirena first line as treatment. Even if you have fibroids, as long as they're small or subserosal or intramural, Mirena is still a viable option and is worth trying. And the problematic fibroids are the large ones or the submucous ones, which can distort the uterine cavity. It's worth checking if your practice doesn't fit Mirena's, if there are any inter-practice referral schemes around who maybe could. Other options include tranexamic acid plus or minus mefenamic acid, and also hormonal therapies, in particular the combined contraceptive pill, or if that's contraindicated, the progesterone-only methods, including oral cycloprogesterone or Depo-Provera. When to investigate heavy menstrual bleeding, consider Papel sampling in women who are over 45 or those who are under 45 with other risk factors for endometrial carcinoma, such as polycystic ovarian syndrome, raised BMI or diabetes. When to refer, if there's persistent intermenstrual or postcoital bleeding, and by that we mean 3 or more consecutive cycles. If you don't have any access to Papel sampling or Mirena fitting in the community. If there are large fibroids on scan, which are causing pressure symptoms or urinary problems or are distorting the cavity, or there's thickened endometrium on scan, suggesting referral, and if medical treatments have failed.